very interesting question. It actually depends on the risks of a patient. If somebody is having a higher risk profile, of course, the disease can progress a bit quicker and can occur at an early age. If somebody's risk profile is low, it can take several years to develop. In reality, the ischemic heart disease means there is narrowing of the heart arteries coming up. The more the narrowing, there will be less amount of blood flow to the heart muscle, and then they develop the symptoms. So it depends on the risks that causes it. It depends on the size of a blood vessel a person has got it, right? And the rate at which we diagnose and they develop the symptoms. Yeah. So it can be within a day. Usually patients develop it in the third decade onwards if they are high risk. And it can progress rapidly. Of course, we can see a 80-year-old with no disease. That means they are low risk. It never develop, but they might develop. Most of the time, we may die even before developing coronary artery disease. But if we live, invariably, most of us will develop. Ischemic heart disease is some sort of extremity of what we call a coronary artery disease. Coronary artery disease is just thickening of the heart arteries. Ischemic heart disease is when the thickening has become more, so that there is a flow of blood is reduced to the muscle. So whenever the flow of the blood is reduced, that means uh, the demand is not met, right? So if we are running, the demand for the heart muscle is more, and if it is not met, then we can get symptoms of chest pain, that is exertional chest pain, but it can progress and become more just on walking, right? Initially brisk walking and then walking slowly. It actually makes a person to gradually slow down, and then they become slower and slower, and they come to hospital whenever they realize it. However, as I mentioned, coronary artery disease leads to ischemic heart disease. Coronary artery disease means there is narrowing or small plaques in the coronary vessels. That is, coronary vessels are nothing but blood vessels supplying the heart muscle. So whenever these small plaques, which are thickening of the arteries, rupture, it can cause bleeding. Like we have scabs, you move the scab on your skin, there is a bleeding. So similarly, heart arteries have got these plaques like scabs. Whenever it rupture, there is a bleeding within the vessel wall that causes a clot, and then those clots can block the artery, and that also lead to ischemic heart disease, even when the narrowing is not severe. So it is a clot blocking it, and in that case, it can happen so quickly and acutely, that is acute heart attacks. So it can happen in an acute way or in a chronic way. Silent ischemic heart disease is relatively very common because, as I mentioned in my earlier response, it all depends upon what brings the increased demand to bring the symptoms on. So the demand is the one deciding. If somebody is never challenging their heart up to that demand, it remains silent. So they won't know it until the disease progress, and then just on ordinary walk or walking within the house, they start getting the chest pain. That means they couldn't do the same work which they used to do it. That is one side. The other situation is, as I mentioned, as cab suddenly actually breaking away, and then it causes an acute heart attack. They may not have necessarily warning because it was not a flow limiting disease in the past, and suddenly it happens. There is also a third choice, which is very common in the past, is some sort of a progressive diabetes mellitus. Diabetes patients can have silent heart attack because they lose the capacity of perceiving the pain because of the diabetes. So that is the original. In the past, we always used to think silent ischemic heart disease is for patients with the diabetes mellitus. However, it can happen in two other ways. Yeah. That's a good question. Ischemic heart disease can be diagnosed with a very simple ECG. Whenever a patient is in pain, we can do an ECG and look at is there an abnormality in the ECG suggestive of an acute heart attack or a strain to the heart muscle, right? However, many occasions the ECG can be normal, but still our patients may require more tests. So the tests we commonly use are two different types. One is this called anatomical test to look at the arteries by doing either an angiogram. The angiogram can be done as an invasive test by taking the patient into the catheter lab, passing a tube in, and then inject the dye into the heart arteries as an invasive test, or at the same time, we can do it as a simple CT scan based test by asking them to come for a CT scan, just inject the dye through a simple like a vein puncture and do it without passing any tube to the heart. So the commonest now advised is if somebody is coming to us with no proven disease in the past, the first line test is a CT coronary angiogram. That is first. The other way of testing it is called functional test. In the functional test, what it is you try to increase the demand to the heart muscle. That is the main idea of the functional test. You increase the demand to the heart muscle and see whether the supply to the heart muscle is sufficient or not. Traditionally, we did it by simply doing an exercise treadmill test, making patients to walk on the treadmill and just watch the ECG. So we didn't watch the blood flow to the muscle, but we watched the abnormality on the ECG. Later on, we moved to something called a stress echocardiography, doing an ultrasound scanning of the heart, at the same time increase the speed of the heart muscle and look at is there any problem to a particular area of the heart muscle coming as new. But we traditionally also have a sophisticated test with a nuclear scan, right? Injecting isotopes, nuclear isotopes, that goes through the blood to the heart muscle. And so we can compare the difference between when we stress the heart and when the heart is at rest. So we can decide which area of the heart muscle has got lack of blood supply over additionally for so many years. So that is a very commonly used test. Recently, with the increasing abilities, we are now doing cardiac MRI scans by stressing the heart, look at the heart through a MRI scan without radiation. But this test takes nearly an hour, right, compared to any other tests. So it is not easily available. It is available at selected centers. So the commonest test we offer is either a nuclear scan or as an exercise test. And then the next common is stress echocardiography. The ischemic heart disease, as I mentioned in my previous answer, is progresses through the disease progression of plaques, that is thickening of the arteries. The more and more thickening, the artery gets narrowed with it become calcified. That means it's become very hard. And whenever it is hard, it is stable. It is only lack of blood supply. So the heart can't manage for a higher demand at the time, and the patients get the symptoms. So there is a warning, and we can go on treat it. But at the same time, sometimes the plaques can be very soft, not hard, and they can rupture and completely occlude the blood vessel, cause major heart attacks. In either way, whether it is hard or not hard, soft, it can cause heart attack. So heart attack is outcome of lack of blood supply to a heart muscle area. It can be a small fiber of the heart muscle or a big area of the heart muscle. So depending upon the extent, we call it as a small heart attack or a severe heart attack, and the muscle damage happens. During the heart attack, there is lack of blood supply to the heart muscle. So that is so immediately what it causes is it causes something called ischemia. That's why it's called ischemic heart disease. Lack of blood supply and the strain to the heart muscle. Other time it start releasing some sort of chemicals out of its muscle fiber. That's what we test when our patient comes in to look at is there a heart attack. But at the same time, this biochemical changes actually result in pain development, and the patient start getting the pain. But even before a patient experience pain, we would see changes in a nuclear scan or a stress echocardiography, right? If we do it, that there is a impending heart attack coming in. And similarly, even before the patient get the pain, the ECG changes are expected to come. That's why ECG is a very valid tool. So there are measures to find out what is happening. There is a strain happening. When the strain is not dealt with acutely in the right way, there is a lack of blood supply to the heart muscle. When the heart muscle does not receive enough blood supply for a particular period of time, they die. That is called a completed heart attack, right? So it is a dead muscle. Dead muscle means it will not come back. That become a scar. So once the heart becomes scarred, the other areas try to compensate, and then there is a surrounding area. This is like we have an injury. Around the area of injury, there is swelling, right? So similarly, in the heart, around the area of this heart attack, there will be swelling. So the heart attack area and also the swollen area won't move. So that lead to heart attack induced heart failure. These type of heart attacks and the swelling are the reasons patients can have abnormal heart rhythm that kills them most of the time. So most of the time, heart attack patient dies either because of cardiac arrest due to abnormal heart rhythm or due to severe heart failure where there is no reserve for the heart to pump blood outside. These are the two main reasons why a heart attack patient actually dies. Okay, what we do is ischemic heart disease first has to be investigated. We do functional test or anatomical test as I described. Whatever the way we do, once we decide somebody has got ischemic heart disease, we need to proceed with an invasive angiogram. That is passing a tube through the arteries, either through the wrist, which is the current common method, or sometimes through the groin approach. We pass the tube up to the heart, inject the dye into the heart arteries, and take X-ray picture. That will tell us the severity of the narrowing, how many places are affected, how many arteries are affected. That helps us to decide what type of treatment we can give. The treatment can be just medical treatment or a stent placement, or if it is in multiple places and we can't do lot of stenting, then they will require bypass operation, right? Coronary artery bypass grafting. What it is bypass grafting is very name wise. You just bypass the blocked area or narrowed area with a graft so that from a good area to the good area, there is a graft place and the blood is being circulated.